Hi all, our paper is on barriers and facilitators of eHealth adoption among healthcare providers in Uganda. This study was a quantitative study. I'm Dr. Namatovu Hasifah Kasujja, the corresponding author of this paper. Our presentation agenda is as follows. We shall have the introduction, the methods section, then we shall look at analysis, ethical approval, how it was attained, the results, discussion and recommendation, and then also we shall finalize by looking at the limitation of our study. Most developing countries have adopted the use of eHealth technologies in delivering improved primary healthcare to the citizens. What is eHealth? World Health Organization defines eHealth as a cost-effective and secure use of ICTs in support of health and health-related fields. So eHealth technologies can be telehealth, telemedicine, mHealth or mobile health, electronic medical records or electronic health records, big data, wearables and sensors in form of IoT, and then artificial intelligence. eHealth adoption plays a very vital role in shaping the delivery of health services by the healthcare providers. The adoption of eHealth enables the universal health coverage for instance, through providing services to the underserved people in different parts of the country through telehealth, mHealth, and teleconsultation. So therefore, the use of eHealth is necessary to provide quality healthcare because it allows a seamless flow of information between the different entities, from healthcare providers to patients, hospital administrators, and everybody in the health ecosystem. So research has revealed that eHealth can be one solution that enables healthcare providers to increase the quality of the service that they offer. Whereas a lot of research has demonstrated the potential of eHealth, you will realize that in Uganda, the uptake of these technologies is still very, very poor. So few studies have investigated eHealth adoption among healthcare providers, yet the success of eHealth technologies depends on understanding the prevailing conditions that facilitate the uptake of technology among healthcare providers, which was the purpose of this study. The methods we conducted, the study settings, we used health facilities in Kampala, Mbarara, Jinja, Mbale, and Gulu. These are health facilities that are found in the central, southwest, western, eastern, and the northern part of the country. Part of the reasons as to why we chose this kind of setting is because we needed to understand we needed to create a regional balance, but most importantly, we needed to also appreciate the regional disparities that can influence eHealth adoption. The selection of the 5 districts and the healthcare facilities was purposive. However, the selection of the participants was a stratified random sampling. So specifically, our focus was on government health facilities, and the inclusion criteria, we looked at healthcare providers that were working in these government health facilities across the 5 districts. The respondents and their corresponding health units, these were the health facilities that we visited. These are the number of health facilities that we visited. The number of health facilities within a given category that we visited. For example, national referral hospitals, we visited only 2, and then we had only 19 healthcare providers. So these are the different participants that engaged in the study. Our study design was purely cross-sectional using quantitative data, and this study covered a period of October 2020 and March 2021. The questionnaires, the study was investigating barriers and facilitators of eHealth adoption, and the questionnaires were basically in English, but we used 3 major themes: a demographic theme, barriers and facilitators. Thematic data of barriers and facilitators that was used on the questionnaire was drawn from existing studies that were conducted in the region. The sampling, we initially distributed 250 questionnaires to those healthcare providers within 78 selected health facilities across the 5 districts. However, 216 was fully filled questionnaires that gave us an 86% response rate. Like I had earlier mentioned, the selection of the healthcare providers was we used stratified random sampling, and the strata was we had 2 strata. That's the area of clinical practice, and then we had gender. So once we ascertained that the different participants could meet the eligible requirement, then we decided the selection of those different participants within a given strata, we used simple random sampling strategy. In total, we used 12 research assistants that helped in the distribution of the questionnaires together with the authors of the paper. Analysis, we used SPSS, but we did specifically 3 types of analysis. We did descriptives in terms of means, frequencies, and standard deviation to help us to understand the demographic distribution of the participants. Also, we did a Pearson's chi-square that helps us to test the independence of the variables, and then we also did cross-tabulation to help us to examine the relationship that exists between the different variables in this data set. Ethical approval, we did ethical approval at the School of Public Health at the local REC, and then we did ethical approval at the national level, that is through Uganda National Council of Science and Technology under that registration number. After those 2 approvals, we wrote to the different health facilities, and after giving us the consent, we first verbally spoke to the study participants, and on approval, we gave them a written consent, and their rights at that moment were clearly spelled out before the commencement of the study. Results showed that, 1, Kampala had, when asked the level of eHealth uptake, we realized that Kampala had the highest users, and yet Gulu had the lowest users. To ascertain the statistical significance of the different demographic data, we employed a 0.05 criterion, and we were able to find out that education level, age, location, gender, and institutional place of practice had a significant contribution, a statistical significant contribution to eHealth adoption. The demographic data, 58% were male, 58% of the participants were male, and 42% were female. And when asked if they had used eHealth technologies prior to the study, 41% had, and 59% had never used eHealth technologies. So we had facilitators, the further results also we had from the demographics. Then we elicited findings from the facilitators and the barriers. And then under facilitators, we were able to thematize the variables, or thematize the factors, and we got three categories. We had the theme of organization, technology, and independent and individual. And in order of main contribution, we realized that under organizational facilitators, healthcare providers intimated that training them about the system and not communicating the eHealth benefits, and also the impact of the eHealth system on the organization-wide processes had a very big contribution to them adapting to use the system. Then technological facilitators, healthcare providers, intimated that the ease of use of these systems, and also having to be able to integrate these eHealth systems with existing eHealth infrastructure, and then establishing common interoperability standards, were pertinent factors that would play into their acceptance to use eHealth systems. The individual factors that received the highest mean contribution were the need for faster execution processes by the different healthcare providers, then their attitude towards change, and then the users' trust in the system. These factors received the highest mean score, implying that they played a lot in facilitating the uptake of eHealth technologies. The barriers, again, we thematized them into four. We had organization, technological, and individual and external. In the order of mean scores, we realized that under organizational barriers, the lack of time to learn new technologies, the lack of proper organizational change management strategy, and the fear to alter their traditional work patterns were factors that received the highest mean score, unlike other factors within the same category. Then technological barriers, the unreliable eHealth systems, the missing standards for patient data, and the lack of appropriate ICT infrastructure were technological barriers to eHealth adoption. Then healthcare providers felt that the digital illiteracy, whereas they could read and write, they had the general literacy, they didn't have the skill to operate these different technology systems. So that also played a lot into their uptake. And then lastly, the external factors, we had the unreliable broadband in terms of the internet and the existing business models being fully funded by the state. So this is a challenge because sometimes there are budget cuts in the health budget, implying that there's lack of sustainability to continue using the eHealth systems because of the small budget that they have. So those were really barriers that they faced. So the discussion, so we were able to ascertain that demographic factors such as education, age, and the location of the respondent's workplace had a high significant contribution to eHealth uptake, and this could be corroborated also from our studies. Individual factors such as the user's trust of the system, the user's attitude towards the system, the digital literacy also had a very big impact on whether or not the healthcare providers would use the eHealth systems, and this could also be cited in other studies. Then organizational facilitators, we realized that the institutional place of work, being in position to communicate the eHealth benefits and also training the users played a lot into the healthcare providers using the systems. Whereas for the barriers, healthcare providers indicated that the lack of time to learn the new technologies and also the fear for them to alter the way they work within the hospital also were some of the factors that hinder the use of eHealth technologies. And this can actually also is in consonance with other studies that have been conducted before. Then we had technological barriers. Technological barriers, for example, we had the lack of appropriate ICT infrastructure, the unreliable eHealth systems. These have a very, very big negative impact, a downhill influence on eHealth technology. Whereas the ease of use, integrating eHealth systems within the existing eHealth infrastructure played a lot in the uptake of eHealth systems, and this can also be found in other similar studies. So our recommendations and future study was saying that any policy that is targeting the integration of eHealth systems should take into account the demographic characteristics of the healthcare providers. But most importantly, also attention should be given to individual, organizational, technological, and external factors. There is need for advocacy from private sector involvement, especially where government doesn't have sufficient money to fund the eHealth budget. Then the private sector involvement comes in handy to help in the sustainability plan of the use of eHealth systems. Our future research should focus on also finding out the adoption of eHealth among patients and health and hospital administrators, because the ecosystem does not only involve healthcare providers, but also it has key players within it. So the limitations of our study, the advent of COVID kind of slowed down, and also it brought a lot participants were jittery to participate in this because of the fear of getting COVID. Secondly, it was purely quantitative, so we believe that we did not give the participants the flexibility of giving us their opinions, which could probably have been a key ingredient in our findings, and also the small sample kind of limits our generalization of our results. However, we intend to address this issue in our subsequent studies. These are our references.